Okay. So again, Assalamualaikum and very good morning, everybody. So you now almost noon time. Yeah, I hope you had breakfast. Yeah, you won't be hypoglycemia. Yeah, while listening to my and then you pengsan pula. Yeah, don't be like that. Okay. All right. So we will now straight to our lecture. Yeah, which I hope to be more interactive. Yeah, more of flip learning, flip teaching other than lecture, yeah, conventional lecture by the lecturer, yeah, didactic. Okay, my name is Benny. Yeah, I'm a pharmacist, clinical pharmacist. Actually, I did my first degree in University of Indonesia back in Jakarta, but very long time ago. Then I came to Penang to USM to do my master's in clinical pharmacy. Yeah, and then I also did my PhD in UKM. Yeah, in the um, interprofessional education area. Yeah, so my hope, my wish is that pharmacists can improve pharmacist practice, yeah, by collaborating with other healthcare professionals. Yeah. All right. So since you already received my reading materials that I posted, so we will just go a bit quicker. Yeah. So the learning outcomes for this lecture, yeah, that you would be able to explain the pathophysiology of dyslipidemia. Yeah. Describe the general approach to management of this lipidemia. So as I said that there will be a lot of um, a long guideline to read, but we can't discuss everything, yeah, in 1 or 2 hours. So just general approach, and then describe the aspects of pharmacotherapy, yeah, clinical pharmacy aspects, and pharmacy practice, and then apply the knowledge to solve cases. Yeah, so that's also important for us. So this is under what lecture? Yeah, clinical pharmacy. Yeah.
Yes, doctor.
Yeah. So can I just ask whether have you gone through the in pharmacology lectures? Have you gone through the drugs for hyperlipidemia, lipid lowering drugs, like the mechanism of actions?
Yes,
Yes, last
doctor.
semester.
Yeah, last semesters. Yeah, okay. So you are familiar with the drugs, so I don't have to repeat again. Yeah. So and anyhow, I didn't make any slide for that. Yeah. So just a little bit of terminology. Yeah. Why do we use the term dyslipidemia? Yeah. And then if you see here, some books will put using E. Yeah. But Malaysia we follow UK English, right? So British English. So it is hyperlipidemia. So a and E here, A and E, yeah. So just like hemoglobin, yeah, HAE instead of HE, yeah. Okay, because why? Because AIM here is the blood, right? Blood component AIM, yeah. So it's not IM because when you use E, then people will read hyperlipidemia, yeah. So it's already wrong. Okay, so the British people, they want to be more authentic, yeah. They don't want to apa so you can debate ya between bahasa Malaysia and bahasa Indonesia kan. Yeah, which one is more authentic, bahasa Malaysia or bahasa Indonesia, bahasa Melayu or bahasa Indonesia? So bahasa Indonesia comes from bahasa Melayu, yeah, and but because they mix with a lot of Javanese and other races, then it becomes, yeah, more diluted. Okay. So and then some books will say hypercholesterolemia, yeah, and but we use this lipidemia. Why this? Anybody knows? Yeah, you can unmute yourself if you want to talk. Yeah, have to be aware of the time also. So anybody knows? Yeah, siapa nih? Malu-malu semua ya? Huh? So here, the one that I saw, Hannah, do you know why we call it dyslipidemia?
I'm not sure, but irregularities maybe?
Irregularities. Why irregular? Yeah. Why we don't say hyper? Why better to use this?
Because I learned previously that dyslipidemia has different classification.
Uh-huh. Yeah, in terms of terminology, yeah, because if you say hyper, what is the meaning of hyper?
High?
Too high, right? So kalau for HDL, do you want it to be high or to be low? HDL to be high,
High.
yeah. LDL you want it to be low. So it is not correct if we say hyperlipidemia because we want HDL to be high, not to be low, yeah. So the higher the HDL, the better. So then we use this lipidemia because some of the lipid we want it to be low, some we want it to be high. Yeah. Okay. So now you know already. Now, do you know what is metabolic syndrome? Do you know what is metabolic syndrome? Yeah. Anybody have heard about this? We very often in the book or in the seminar or when your lecturers also use this word, this term metabolic syndrome. Do you know? Anybody, please? Ya, Safwani. Siapa namanya Wani kah panggilannya?
Putri.
Hah?
You can call me Putri.
Oh, Putri. Okay. So Putri.
One of the metabolic syndrome is like diabetes mellitus,
Yes.
heart disease, something like that.
Yeah. So we use the term metabolic syndrome when there is a diabetes, hypertension, and hyperlipidemia. Yeah, dyslipidemia. So if these three occurs in one patient, yeah, especially the fourth one is when the patient is obese, have central obesity. You know what is central obesity, right? So you know the body, so the central means the stomach, yeah, is bigger, yeah. So central obesity. So you have central obesity, you have the dyslipidemia, diabetes, and hypertension. So these are very common in people, right? They come together like a package. Yeah. So this package is not a good package. Yeah. The package is metabolic syndrome. Okay. Now, so this lipidemia itself refers to the following lipid levels. Yeah. So our criteria when we say, oh, this is this lipidemia. Yeah. So when total cholesterol is above 5.2. Yeah. In Malaysia, we use millimole per liter. But if you read books like Dipiro, you know Dipiro, right? Kodak Kimball, yeah. So they will use American one. Yeah. The American one is in milligram per deciliter. Yeah. And then HDL cholesterol less than 1, yeah. For males and females less than 1.2. So female criteria is higher for HDL, yeah. And triglyceride TG above 1.7. Okay, LDL actually there is no value, yeah, fixed value for LDL. It depends on the patient's cardiovascular risk, which we will see later. Yeah. All right. So when we talk about lipid, right, and if you go to Mydin or go to Giant, yeah, Tesco, you go and check oil, yeah, cooking oil. Then they will put no cholesterol, right? So do you think this is true or false? No cholesterol. Yeah. Are they deceiving the customer or not? Coba if you go and then you know at home also you can see the bottle, yeah, of the the cooking oil, yeah, you will see there is written there no cholesterol, yeah, so that people feel, oh yeah, safe lah, no cholesterol, yeah. So is it true or not true? Ayo, please be more active, ya. Ima,
Don't know.
Siti tadi ya, Siti Naziha ya.
I don't know.
You don't know, okay. What do you think? What do you think? Yeah, if you make mistake, it's okay. Yeah.
Mm.
I think
Huh?
it says like no bad cholesterol, but the overall cholesterol is still there. I'm not
Cholesterol is
sure.
still there. Okay. Anybody else have different opinion? Cuba. The others, are you present? Nurul Akila, Hilman Hadi. Normally pharmacy classes are more girls, yeah. Cuba the boys, the men, mana tu? Victor Tan. Priscilla, mana lagi? Okay, so actually it is correct, yeah, no cholesterol. Why? Because cholesterol only we only find cholesterol in animals, kan? So because cholesterol is abundant in the what do you call this membrane, cell membrane, yeah, and cholesterol is only in the animal. So when plant, there's no cholesterol, okay, but oil contain a lot of lipid because lipid is triglyceride, yeah. So there is a lot of triglyceride in the oil. Basically oil is triglyceride, okay, and then there's fat and oil. What's the difference? Yeah, fat, yeah, fat and oil, yeah. Normally fat is, oil is in the liquid form, yeah, fat is in the solid form, okay. And then you have phospholipid, okay, so it's a lipid as well, yeah, they have the phosphorus there, and then there's a sterol, yeah, cholesterol is a sterol. So cholesterol is also lipid, yeah, that's why we say dyslipidemia, okay. So there is no cholesterol, but will it be dangerous or not when we have too many, we consume too much of oily food? Yeah, dangerous or not dangerous?
Probably.
Okay, so you like the mee goreng mama and all this, right? Dangerous or not?
No.
No?
Because
But
Okay,
it's delicious.
it's
so
it's
so triglyceride, yeah, consists of three molecules of fatty acid and cholesterol, glycerol, sorry, yeah, so glycerol and fatty acid. So I just want to review a bit of this fatty acids thing, yeah. So because we need the fatty acids, yeah, so it becomes triglyceride, and then it will be in the body. Triglyceride will be hydrolyzed again to glycerol and fatty acids with an enzyme called LPL, yeah, lipoprotein lipase, right? This LPL is important because it is an enzyme that will hydrolyze again the triglyceride, yeah. And then you have the role of triglyceride actually to store and distribute energy, yeah, because lipid is the main function problem, Bu Enti.
can't hear you.
Yeah, no, just now was correct. My connection suddenly off. I'll share again. I hope that the recording is okay, still recording. Yeah, so we have, okay, so to store and distribute energy, yeah, important. An example is triglyceryl stearate, yeah. So if you are good in organic chemistry, yes, stearate is C17, yeah. So you have C12 laureate and then C15 valerate, yeah, C16, whatever you have it, if you are organic chemistry, yeah. Yeah, so cholesterol, okay, cholesterol Now, it is important for us to know that we have 80% of cholesterol from food and 20% synthesized in the liver. Okay, so so our sources of our cholesterol. Now, functions, component to make cell membranes. Yeah, so we need also cholesterol. We cannot be like totally no cholesterol. Then how we will make the cell membrane? Okay, then precursor of steroid hormone, vitamin D, and bile acids. Yeah, so so cholesterol is needed, but we cannot have too many lah, too much. Yeah, cannot have too much. Now, metabolism of triglycerides. All right, so this is the biochemistry. Yeah, so fatty acids can produce acyl CoA or acetyl CoA. Yeah, so this acetyl CoA will go inside the Krebs cycle. Yeah, and then it will create the ATP, right? So in the Krebs cycle. So that's how actually if we are lack of glucose in our body, so the body will break down lipid and amino acid, yeah, to be the source of energy. Okay, so what we call lipolysis. Yeah, so lipolysis here, lipolysis. Yeah, also so there is a connection between the lipid, amino acid, and carbohydrate. Yeah, these three most important component of our diet. Now, just now we mentioned about cholesterol, yeah. Cholesterol, synthesis of cholesterol, the precursor is acetyl-CoA. So you see acetyl-CoA come from the this one what? The free FFA, free fatty acid, yeah. Free fatty acid will make acetyl-CoA. So just now when we relate, yeah, the cooking oil just now kan, the cooking oil has a lot of triglycerides, right? So it produces a lot of acetyl-CoA. So the acetyl-CoA that produced by the triglyceride, yeah, can produce cholesterol. So even though we don't take, for example, you are vegetarian. So many Indians also vegetarian, right? So you are vegetarian. Some people become vegan. Vegan means totally, yeah, no egg, yeah, so totally very purely vegetarian. Okay, so if you are vegetarian, you did, oh, okay, we don't consume any cholesterol, yeah. But how the body will get the cholesterol, kan? Because the body have to synthesize the cholesterol, yeah. Now synthesize from the lipid, yeah, from the acetyl CoA, from the cooking oil and all this, yeah. So it will also be produce cholesterol, yeah. So this is how we have to tell our auntie and uncle, yeah. Although it is said no cholesterol, but this will be the precursor of cholesterol, yeah. Okay, so let's go to our case now. Yeah. So we have maybe somebody wants to read the case so that not only me talking. Yeah. Anybody? Let us see any men or not in this class. Iksan is my student. Yeah. So Hilman, are you there?
Yes, sir.
Hilman, boleh baca ini?
Boleh. Okay.
Yeah.
Alex, a 48-year-old man, came to the KK Klinik Kesihatan after being advised by a community pharmacist. Last week, he visited a community pharmacy and had a random blood sugar test, and the result was 13 millimole per liter. Below are his medical history, social history, physical examination, and lab results.
Okay, so you can continue.
Okay. Personal data: body weight 70 kg, height 165 centimeter, smokes one over two package a day since the age of 20, deny drinking alcohol, occupation, Sundry shop owner, married, having 2 children, aged 10 and 7 years of age. And family history, his father passed away at age of 54 due to heart attack. He had a history of diabetes mellitus type 2 and hypertension. His mother is still alive, age 65, suffering from hypertension, diabetes mellitus type 2 and dyslipidemia. He is the eldest with 2 other younger sisters who seem to be in good health.
Okay, so let's start from here. Body weight. Is he any, so this person, has he been treated before? Huh? Has he been treated before?
I think no.
No, yeah. So he just happened to go to the pharmacy, yeah, go to Caring or whatever pharmacy, yeah, and check the blood sugar, and then found to be high, yeah. So he went to KK, yeah, and then now when we have the body weight and height, straight away we think about BMI, yeah. How to calculate BMI? Do you know? How to calculate the BMI?
Weight over height square.
Yeah, so weight 70 kan over 1.65 the square, first. So what do you know, what is the result?
25.7.
Okay, 25%. So now can you assess this 25.7 whether he is overweight ka or obese?
Overweight.
A little bit overweight, yeah. So if you follow the WHO one, so it is above 25 is overweight, yeah. 25 to 30 overweight, yeah. After 30 is obese, done, yeah. 30 to 40 obese, and above 40 we call it morbidly obese. Morbidly obese means, yeah, already become a disease. Okay, so now so 25, but be careful, yeah. For Asian, actually we have a lower one, yeah. For Asian, some guidelines put 23, yeah. So above 23, so is considered as overweight for Asian, yeah. So I noticed, yeah, for us also Malaysian, yeah, so many people hide behind the baju kurung, so I cannot see the overweight, yeah, because baju kurung is big, so you cannot see they are already obese, yeah. So now smokes half package. So do you know how to calculate the smoke pack years? Yeah. So there's a pack year. So one pack is around 20. One pack is 20 cigarettes. Yeah. So if we put one pack per 1 year means one pack year. So now 20 years, since the age of 20 years, 48 years now. So 28 years he has been smoking, right? 28 years, yeah. So 28 years times half. So around what, 14, yeah. So 14 pack years. So if we calculate the pack years, 14 pack years. Okay. So if he said that, oh, I smoke maybe like 10 cigarettes. 10 cigarettes is half pack. Yeah. 5 cigarettes mean 1/4 pack. Okay. That is the standard pack of the cigarette, 20 cigarettes per pack. Okay. So occupation ni kedai runcit, ya, sundry shop, ya, kedai runcit. Okay. In Indonesia, you know what is kedai runcit? They call it kedai apa? Toko kelontong. Yeah, not lontong, ya. Not lontong. Now talking about lontong, then you become hungry already. All right. So married with 2 children. Yeah. Okay. For family. So does this patient have family history of CVS? Yeah. CVS. Yeah. So very high history, right? Both father and mother. Yeah. And why it is important to say that his father passed away at the age of 54. Yeah. For us Asian, we don't want to ask people, ya. Ya, umur berapa? What age is your father died? Why you sibuk-sibuk yang menyibuk sangat tu, ha? Right? Asking people's age, ya. But this is important because guidelines say, yeah, for men, yeah, relative like father or grandfather or son, yeah, that died below 55, yeah, it's mean premature death. Okay, so below 55 for men, and for women below 65. Okay, so men if die before 55 means you are young, you die young. Okay, if women die before 65 means you die young. So I always tell my students, kalau if you want to have your husband and wife die together, then you married 10 years older wife, yeah, then you die together. Just a joke, yeah. No, he's the eldest, yeah, and then he doesn't know about his sisters, yeah, how their health, but he said maybe nothing, yeah. Okay, so continue. So what is NKDA? Are you familiar with this term NKDA?
No, please.
No known drug allergies, yeah. Okay, so good. PMH, what's PMH? I purposely use all this abbreviation, yeah, so that you are
Patient medical
Yes, medical
history.
history.
okay. It's past medical history, yeah. So some people say, why already past then history? History is past what? Yeah, where got history future one, right? Yeah, but this is the common mistake already used, yeah, common mistake, yeah. So past medical history, nothing significant except for dengue fever, yeah. So common dengue fever in our area, yeah. Medication, so now for 1 or 2 years more, then we say that except for COVID-19. Yeah. And medication history, not on any chronic medicine. Yeah. Vital signs, BP, high or not? BP. Yeah, the BP is high. Yeah. So he has got hypertension actually, kan? Heart rate is normal, respiratory rate normal, and the temperature is normal. Okay. Physical examination, Santel asthma. Sorry, how you call it? Santel asthma. Yeah. Seen in both eyes, but no arcus senilis. What is that? Santel asthma, arcus senilis. What is that? And xanthoma. So Santel asthma is here. You see the lipid deposition, yeah, around the eye area. Okay, this man has 1, 2, 3, 4, yeah. So have you noticed this uncle, auntie normally have this? Have you noticed? Yeah, some of your relative. So if they have this, then it is a sign of high cholesterol. Yeah, high triglyceride and cholesterol. So you can tell, oh auntie, ya, makcik, ya, makcik ada kolesterol ke, kan? Nanti dislike pula, menyibuk kau katanya kan. Okay. Now, so this is the hypercholesterolemia. There is a what you call palmar xanthoma. Yeah. So never mind. I will share with you all these slides. Yeah. So you don't have to write down. Striate xanthoma. Yeah. Palm creases in English. Okay. And then arcus senilis. If you see the old people, yeah, they normally they have this halo, yeah, white color. Yeah. So like a light bulb. Yeah. So this is arc, the arc is, like the arc, and then senilis means old. So actually, normally you see this in old people, yeah. But if you see this in young people, so it means that they probably have a high cholesterol, yeah. And then you have got Santel asthma, just now we saw already, yeah, for this person. And then you have the tendon xanthoma, yeah, tendon xanthoma. So the tendon here, yeah, there is a lipid deposition, okay, and in the Achilles tendons also, as well, yeah, okay. And then you have eruptive xanthoma, yeah. So probably you can ask people to show you, yeah, the eruptive xanthoma. And then now the lab test, okay, potassium a bit low, yeah. So do we need to treat the potassium a bit low? Yeah. So probably we ask him to have more fruits, yeah, like banana or what, yeah, can increase the potassium. Okay. And then fasting blood sugar is high, HbA1c is high, yeah. So this patient definitely have diabetes. So, but we have to, today we are talking about hyperlipidemia, so we will ignore the diabetes, yeah. But the patient comes with diabetes as well. So we have the total cholesterol. So this is called lipid panel, yeah. So if you go to hospital, the doctor mentioned lipid panel, lipid panel. So lipid panel is all this total cholesterol, HDL, triglyceride, and LDL. Yeah, and you realize that LDL is missing here, so I purposely took out the LDL, yeah, so that I can tell you how to calculate the LDL. Okay, then you have the AST and ALT. Yeah, why it is necessary, the AST and ALT? Why at this point? Anybody?
To check for liver function.
Yeah, why we need to check for liver function?
Or metabolism.
Yeah. Anybody?
Is the site for lipidism?
Siapa yang cakap ni? Tak nampak. Okay. Okay, so because we are going to treat with statin probably, yeah, so we need the AST and ALT. Later we will see, okay, why we need baseline. So you call it baseline, yeah. Before you treat, then you take first the baseline, yeah. All right. So you all are in Shah Alam or in other places? Selangor, all Selangor, yeah. Or you go back your hometown. Hilman di mana Hilman?
Shah Alam.
Shah Alam. So Putri? Balik
In
Sabah.
Kedah.
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 Kedah. So you all now balik kampung lah, ya. Yalah, ya. It's better because then, but Kedah has high COVID kan, berapa ya ini? Sebab a few weeks ago, ya.
Yep, at my hometown.
Yeah. All right. So LDL is not available in the lab results. Yeah. Could we find out by calculating? Yeah, calculation. So actually there is a LDL in the lab. Yeah, it is by calculation, but the machine will calculate for us lah. Yeah. So the LDL is TC, total cholesterol, minus HDL plus triglyceride divided by 2.2. Yeah. So this is called Friedewald's equation. Okay, this equation is if we use the millimole, like what we use in Malaysia. Yeah, but if you US based, like Indonesia is US based. Yeah, so then you will divide triglyceride by 5 because the triglyceride is like 200. Yeah, in Malaysia, in Indonesia or US based results. Yeah. And then LDL, so if we calculate for this patient around 4.15, yeah, which will be high, yeah. Okay, if the TG is too high, more than 4.5, this formula is not accurate, yeah. So then we will calculate the non-HDL. The non-HDL cholesterol means the TC, total cholesterol, minus HDL, yeah. So we use the non-HDL is preferred when triglyceride is too high. Okay, so why do we call LDL bad cholesterol and HDL good cholesterol? Anybody knows at this point? Again, so this is the language of apa? The lay language, yeah, the lay language. The terms use bad and good cholesterol. So I would like to hear from you, yeah. Ada juga my students from Jakarta here. So why do we say good and bad cholesterol? What is so good of them? What is so bad of them? Siapa ni ya? Coba Victor Tan. Are you with us?
Yeah, I'm here.
Are you a student or a lecturer?
Student.
Because nanti I panggil tu lecturer ya. Victor, do you know why we call certain cholesterol bad, certain cholesterol good?
I think the HDL will bring the cholesterol back to the liver and excrete it, is it?
Yes, yes.
But the LDL is vice versa lah.
Okay. So yeah. Thank you. So I think you have the basic knowledge already. Yeah. So LDL, because in the epidemiology study, yeah, they found out that those patients with LDL, high LDL, tend to have to develop the atherosclerosis, right? The coronary artery disease. Yeah, and those with high HDL tend to be protected. Yeah, then also supported by the biochemistry study. Yeah, that HDL have the role to conduct the LDL back, yeah, to its receptor, so it can be metabolized and broken down. Yeah, so HDL being good, so good because it lower down the LDL. Yeah. So now, have you heard about apolipoproteins? What are they, and what are their roles in dyslipidemia? Have you ever heard about this, or not too sure? So siapa coba Kishantini, are you with us, Kishantini?
Yes, sir.
Yeah. Have you heard about apolipoproteins?
Yes, sir.
Yes, yeah.
In my a few sense before.
Okay, good. Yeah. So if you have this lipoprotein, yeah, looks a bit like, what do you call this? Ferrero Rocher ya, yang coklat tuh. Ya, yang so in the here that you have kacang-kacang here, yeah. So your nuts here, yeah. So you have the apolipoprotein, and then you have the free cholesterol, yeah, and then phospholipid, because phospholipid have the head, yeah, the head hydrophilic and lipophilic, the tail. Yeah, the tail is lipophilic, the head is hydrophilic. Yeah, then you have the triglyceride in the core. So the chocolate is the triglyceride. Yeah, and then you have the cholesterol ester. Okay, so Koda Kimball have this picture. I think this picture is also nice. Yeah. So and then you have the apolipoprotein. Yeah, there are many types of apolipoprotein, the CB100E. Yeah, so the more recent developments, yeah, research find out, yeah, their purpose. Actually, apolipoproteins have a lot of purposes. Yeah, so some of them are good, some of them are not good. Yeah, in terms of benefit. Okay, so if you want to read, I won't be reading this, but I just tell you. Yeah, so there's a chylomicrons, VDL, VLDL, right? It's on VLDL, LDL, HDL. So there are the main apolipoproteins in each of the cholesterol type. Yeah. So the largest cholesterol actually is the largest lipoprotein, yeah, is the chylomicron. So we talk about LDL, HDL, they are not cholesterol per se, yeah, they are actually lipoprotein, okay? But they are the transporter of the cholesterol. Inside there are cholesterol inside, okay? So, and then you have, according to the size, yeah, the size, okay, chylomicron is the biggest, and then VLDL, LDL, then HDL is the smallest one, yeah. And the smallest one is the most important one, okay. So don't look down on the small people. So they may be the most beneficial one, yeah. And cholesterol, so their content, yeah. So if you see the chylomicron and VLDL, they have very high content of triglycerides, yeah, because they are the first transporters, yeah, of all this from the food, yeah, the chylomicron, So I think as you have already know what is apolipoprotein, yeah. So for example, just now we mentioned about B100, yeah. B100 function is triglyceride and cholesterol transport, yeah, and binds to LDL receptor. So since it is like the conductor, yeah, that the driver, yeah, that drive this phospholipid, yeah, go to the receptor and bind them, yeah. So the B100, the more the B100, the better, right? Because it will bind to the LDL receptor and transport also the triglyceride and cholesterol. So, and then some are very good one like C2, yeah, activates the LPL. LPL is lipoprotein lipase, which is very important to break down the triglyceride, yeah, activates the LCAT. So all these are useful one. But the cholesterol acyltransferase actually, yeah, lecithin. Okay, later we will see the role of this LCAT, yeah. Activates, so A1, it activates the LCAT. So apolipoprotein protein component in the lipoprotein, their functions to maintain the integrity of the lipoprotein structure, regulate certain enzymes in the lipoproteins, and identify the receptors. Yeah. So are you tired already? So metabolism of lipids. Okay. So I think I don't have to repeat this. Yeah. So there is an exogenous cycle and endogenous cycle. Yeah, so the endogenous cycle means that synthesis of the lipid, yeah, the cholesterol, yeah, by the liver. The exogenous one, yeah, is from the food one. Okay. So and then you have the HDL that bring, yeah, the LDL to the scavenger cells, yeah, and then back to the LDL receptors. Yeah. And then what are the LDL receptors here? Yeah, a glycoprotein that is in every cell binds to LDL. Inside the cells, LDL will be broken down. Yeah, so when we have the reduced number of LDL receptors, yeah, we will have the hypercholesterolemia. Now, ApoB, so apolipoprotein, you just call it Apo, yeah. ApoB mutation disturbs the binding of LDL with its receptors, yeah. So if let's say we are lack of ApoB, yeah, so the LDL will not bind to the receptors, yeah. So it causes the family hypercholesterolemia. So there's a type of hypercholesterolemia called family hypercholesterolemia, yeah. So it is because of the genetic problem, yeah, defective ApoB, deficient of ApoB, yeah. So this is how the what is our concern about this high cholesterol is because the high cholesterol will be deposited, yeah, in the blood vessels. Okay, so it will form the atheroma, yeah, and when it build up, yeah, it will be broken down. So it will be broken down, yeah, and then it will cause more and more blood clot, yeah, and then it will clog the blood vessel, yeah, and then the patient will develop the ischemic heart disease, yeah, or coronary artery disease. Okay, so this you can read by yourself, and I don't need to. So you see how the atherosclerosis happen. So this is now disconnected for a while. Yeah, so it is back now. So are you still? So are you hungry already? Yeah, surely hungry already. Yeah, 1 p.m. already. Yeah. Do you need some rest? Dulu apa? Break? Huh? To refresh yourself? Sudah? Huh? Do you need some break, Miss Anty?
I think can proceed because beside them a lot of food already.
Who?
Right?
The students, do you need to some break to go to toilet ka apakah? Nah?
Did you need some break or not? Because you have class at 2, right?
Maybe 5 minutes break first. 5 minutes break.
5
Okay.
minutes. Okay.
Okay, yeah. 5 minutes break,
So
yeah.
just stay on this line. Okay. Don't
Yeah,
exit.
yeah. Bagaimana Bu Enti? Too slow or not?
No. Standard. Okay. This student actually, Pak Ben, they are what do you call that? Sem 5, first time to study the clinical subject. Okay, so maybe some terms, abbreviations, they're still not familiar lah. Like just now PMH, and then what else? Some kind of test, LFT test.
Yeah. Yeah, good.
Still
But
not familiar.
yeah, it's okay. So we make them familiar, yeah, so that before you go to apa hospital, you're already familiar.
Yeah. They start by next sem.
Next sem, yeah.
Next year. Sorry, next year. How the student still can go to hospital or not in Indonesia?
I don't know. As you know that we don't normally send the undergraduate kan. Normally only the apotheker.
Oh yeah, okay, yeah, on the apotheker. But still they go or not? Still can go,
I'm not sure, but actually JGU students, many of them are matured students, so they are working in hospitals as a pembantu farmasi apa we call penolong farmasi.
So here in your student is or what? The one who joined this time? Full-time student?
Some of them are working actually, but they just join, I think, just to listen.
Yes,
Yeah.
okay.
So maybe I call some of them to see whether they are introduce.
Which hospital? Yeah.
Benny. So I have students with the same name as me. Benny.
You call your name.
Ben, are you there?
Yes.
Ya, coba tampilkan dirimu. Dirimu yang handsome ini.
Oh, are you in hospital or at home?
Mana Ben nih? Ayo Ben. Oh, you're working ya, Ben?
Working.
Yeah.
Actually, Pak Ben.
Yes.
Oh, working. Actually, you know what the significant difference? What pharmacist scope in Malaysia, in Indonesia, here they don't have dispensing, you know.
Yeah.
I think we can collaborate later. Can ask your student how to do dispense like some powder. How to.
Yeah, betul.
Like Benny is still in office, right? I mean in hospital kan. So bolehlah dia tunjukkan macam mana nak dispense ubat. Some day lah, not today.
Yeah, can Ben? I forgot to pause the.
Cannot answer. What?
Okay, let us now restart. I share back the. Okay, just now we are until here. Okay, so there is also a classification of dyslipidemia, where there is a type 1, type 2A, 2B, 3A, 4, and 5. And you can see the difference here. When you centrifuge their serum, or plasma or serum, so then you will, no, I think it's a serum here, so you will see more of the, like the normal one should be clear, serum should be clear, okay, but the type 1, then you have more chylomicron, the type 2A, more LDL, type 2B, etc. Actually, you are not supposed to, we don't expect you to memorize this lah, just to understand, to know there are few types, okay. And okay, so I still have the Bahasa Indonesia pula here. I forgot to change. Okay, so there's also some genetic causes of this lipidemia, like familial hypercholesterolemia, etc., etc. Yeah. Yeah, mostly it corresponds to this Fredrickson. Just now, the one that I show you is a Fredrickson. Yeah, Fredrickson. Okay, and then so this genetic causes can cause a risk of CHD. You know what CHD? Coronary heart disease. Yeah, and if we have too high of TG, yeah, triglyceride, it can cause pancreatitis. Okay, so lipoprotein lipase deficiency, because lipoprotein lipase is important for to break down the triglyceride. Yeah, so if you have the lipoprotein lipase deficiency, then you have a high triglyceride, and it causes pancreatitis as well. Okay. So then other classification, which is simpler, yeah, like predominant hypercholesterolemia. So you are both total cholesterol and triglycerides. Yeah, the elevated one is LDL and VLDL. Okay, and there is also hyper alpha lipoproteinemia. So you have elevated lipoprotein HDL, which is actually very good. Yeah, and you have the CHD risk is 0. Yeah, yeah, because you have high HDL. Yeah, although you have high also TC and TG. Yeah, but the HDL will kind of protect. Okay, and there's a predominant hypertriglyceride. So there are patients also predominantly high triglyceride. Yeah, like my mother has a high triglyceride, more than the LDL. The LDL is normal, but the triglyceride is high. And then mixed hyperlipidemia, so both the LDL, VLDL, and also the triglyceride is high. Yeah, so this is when in clinical, I think this classification is better in clinical, because you can, whether it is predominate high in LDL, or it is a mixed one, yeah, with the triglyceride. I think this is the more relevant in clinical. Yeah. And then now our case, yeah, we calculate the CVD risk of Alex, yeah, using the Framingham risk scoring system. Yeah, so I refer to the Malaysian CPG, which I shared with you. So it's actually quite easy. So there is a table here. Yeah, so for the age, so if you see here, the older the patients, first of all, we need to segregate between men and women. Yeah, unfortunately, there is no gender in between. Yeah, either you are man or you are woman. Okay, in this Framingham lah. So so the older the person, yeah, the more the points. It means the higher the risk. Okay, then HDL, the higher the HDL, the less, yeah, some HDL very high, then they become minus point. Okay, so the HDL, the lower your HDL, the more the risk. Total cholesterol is the higher total cholesterol, the more the risk. SBP, yeah, the BP, the more the BP, the higher the BP, the more the risk. And treated, so you need to differentiate between whether the patient is treated or not treated. If the patient is treated but is higher, so it have a higher risk. For example, like the same patient's 140, but if the patient is not treated, it become 2, yeah, the point. But if the patient is treated, it become 4. Why? Because it means that this is a very stubborn, yeah, already treated but still high. It means that the patient have more risk. Okay, so smoker, yes or no? If yes, then set away 4 points. Yeah, there is no, like, you know, in the smoking, there's no light, yeah, moderate smoker or severe smoker. There's no nothing. Yeah, even if you smoke 1 or 2 cigarettes a day, it's already yes. Okay, and diabetes here is also no and yes. Yeah, so if there's diabetes for men is 3, for women is 4. Later we see. Yeah, so for Mr. Alex, because the age is 44, so the score is 5. HDL 1.1, the score is 1. TC 6.2, 6.2, we see 6.2 is here, is 2, yeah. SBP 148, 148, just now Hilman said, the Alex has treatment or not treatment for hypertension? The first time, no treatment, yeah, so we use this column, no treatment, so 148 means 2, yeah, and smoking, it means 4, and diabetes, it means 3. So we total up this risk and we have 17, yeah, so grand total 17, yeah. So what does it mean, the 17? So 17 means, so here total point 17, so it means 29.4, yeah, 29.4% risk for CVD in 10 years. So in 10 years time, yeah, around 30% of patients like this, yeah, will develop the CVD, okay, in 10 years, yeah. So anything above 20, so anything above 20, so 20 is here, yeah, anything above 14, yeah, total points, anything about 20%, it means high risk, yeah, so it's already high risk. So our conclusion, Mr. Alex has a high risk to develop CVD in 10 years, okay. So this one is for women. Yeah, women have different set. Okay, even the age and even the SBP here also different. Even the smoking. Yeah, if smoking just now for men is 4, for women is 3 only. Okay, and for diabetes for men is 4. I don't know why. If women smoke is less risk. Why? Yeah. Anybody knows or not? Just a guess lah. I also don't know actually. Why if it is interesting to know. Yes, Naziha?
Probably estrogen. Probably.
Oh, ada estrogen. You mean estrogen protect? Yeah. Yeah, probably. Yeah. Yeah, good guess. Okay. Or maybe the woman, if they smoke, they don't smoke like chain smoker like men. Maybe, I don't know. Yeah. Yeah. Okay. So diabetes, anyhow, diabetes, if woman is yes, is 4. If man is 3 only. Yeah. Why then woman is 4? Why? Yeah, I'm not so sure about the real reason here. Yeah, but we just follow the algorithm. But I think it's because it is rarer for women to get diabetes. Maybe, yeah, it's more in men. So if a man get diabetes, it's like a common lah. Yeah, but if woman, so it's rarer. So if you get diabetes, means you have a higher risk. Your risk is higher. Probably lah, yeah, but the most important is we follow the score, because this scoring is through the research with so many patients, yeah, thousands of patients. Okay, so this is the year risk for the women, yeah, and then now this most important here also risk stratification. So just now we said that, so the patient will be classified as very high risk, intermediate, or low risk, yeah, depending on, let's say if the patient have established CVD, yeah, already got CVD. So if you already got CVD, no need to calculate already what age lah, smoking lah, diabetes, no need. You already got CVD means you're already very high risk. Okay, and any patients with diabetes, no need to calculate actually. Yeah, all the patients with diabetes, you already got very high risk. Okay, and with the CKD means kidney disease, yeah, chronic kidney disease. Yeah, so it's already stage 3, means you have high risk as well. And then very high level of individual risk factors. Yeah, like Mr. Alex actually is in the under high risk because it has diabetes, and also very high risk, 17 points. Yeah, so it's already high risk. Okay, Anna, multiple risk factors that confer a 10-year risk of more than 20. Just now we calculated for Alex is 29 point something, almost 30. Yeah, so it's definitely high risk. And then intermediate. So this high risk and all this, why? Yeah, what is the purpose? Yeah, the purpose is for treatment. Yeah, Those with intermediate and low risk, we don't need to start. It's not there's no hurry to start with drugs. Yeah, we can tell the patients to have a healthy lifestyle. Okay, like diet. Yeah, we will see later what is the healthy lifestyle. Okay, so how should we treat Alex dyslipidemia? How? Anybody wants to attempt answer? How should we treat Alex hyperlipidemia? Already masuk masa-masa lapar. Yeah, but maybe we should be more active so that we,
So can we prescribe
prescribe? Yeah,
statin?
Yeah, N, yeah, your name is N, yeah, Joanne, yeah. Joanne said prescribe statin. Okay, good. Other people?
Together with change of lifestyle.
Yes, yeah. So first of all, lifestyle must be first. You have to, yeah. So we have the target LDL. So if you refer to the Malaysian guidelines is the latest one, 5th edition, 2017. But now it's already 3 years, yeah. So if American guideline, it updates every year, okay. So whatever you learned 5 years ago, it may change, yeah. But the principle is the same, just the detail will change. Yeah, so if you have the principle, you understand the principle, you will be very fast to learn some new changes. Yeah, so the target LDL-C, okay, cholesterol LDL. Yeah, so for Alex, what's the target? Alex have a high risk. Yeah, so the target will be LDL. Yeah, if we need to treat, this one is not the target for him. Yeah, wah, must be more than 2.6. No, if 2.6, more than 2.6 mean we need to treat with medicine. Yeah, with medicine. Okay, if lower than 2.6 or a reduction of more than 50%, so this is the target. So our target, yeah, so this one is if you read first the title, yeah, LDL level to initiate drug therapy. It means initiate drug therapy, yeah. So definitely for Alex, we have to initiate drug therapy, okay. Now the target should be less than 2.6 or a reduction of 50%. So we must remember reduction of 50%. Why? Because let's say, yeah, this is an OR, yeah. Let's say the LDL is, let's say 6. For example, very high, 6 or 7, yeah, 7. So what do we do? So if we want to target less than 2.6, it means within 1 to 3 months, yeah, the cholesterol must drop from 7 to 2.6. Too high or not? It's a jump, right? So the guideline, yeah, give a little bit of mercy. Okay lah, if your cholesterol LDL is more than 6, for example, more than 6, yeah, more than 6, then you need at least to reduce by 50%. If 6 means you reduce to 3, right? So if you're 6, then within 3 months you become 3. Okay, congratulations, tahniah, yeah, you achieve the target. Okay, although it is not yet below 12.6, kan? 3 is still above 2.6, kan? But the patient have made effort, yeah, to reduce more than 50%. Understand or not? Yeah, so this is how you read this guideline. Okay, now just now we said that if the TG is more than 4.5, the LDL is not accurate. Yeah, so then we use the non-HDL-C level. Yeah, the non-HDL, this one is 3.4 because non-HDL is TC minus HDL. Yeah, so it will be a bit higher. All right, so the principle is just that if the triglyceride is more than 4.5, the LDL become not accurate. Yeah, so we use the non-HDL, right? Now, recommendation, straight away Joanne recommend statin, yeah, which is correct. But just now Vida, said that we must recommend first the TLC, therapeutic lifestyle changes. Yeah, so you can read this. I won't be reading because of to save our time. Yeah, so so actually, is it enough when we tell the patient, oh, makcik, pakcik, please, you have to eat diet, yeah, eat less fat and all this. Is it enough to say like that? Exercise, yeah, enough or not to say just that only?
No.
Makcik kena exercise, yeah. And then the pakcik said, yeah, bye bye, like that, right? Is it enough? No. So how would you counsel them? Huh?
Can we tell them to eat fiber, like more vegetables?
Yeah. So more detail, right? And before you tell them, ask them first, kan? Ask them their habit, yeah, their diet habit, yeah. Kalau, for example, they are so poor, they never eat meat also, yeah. So they only eat vegetable. So you don't need to tell them to eat vegetable every day. Also they eat vegetable, kan? Yeah. So first we have to find out their daily life, yeah, and see also their the posture of the body. If they are so obese, yeah, you have to be more aggressive, kan? And then they are exercise. So exercise is not just exercise, but yeah, see the patient's possibility, okay, and tell them the best exercise is aerobic exercise, kan? Yeah, aerobic exercise. But you don't tell the patient, oh, you go and jogging, yeah. So if the makcik already 60 years old, you go and jogging, then patient maybe die on the road, right? Pengsan or die. So maybe they can, have a brisk walking or what, yeah. And so actually once, just a few years ago, I accompanied my students, yeah, Monash student. We went to KK, yeah, and then we observed because this KK Tanglin got Monash doctors operate clinic every Wednesday like that, yeah. So I sent my students also with the medical students, yeah, go together to the KK, and I happened to go to the KK, and then I happened also to observe this makcik, yeah, being treated and being counseled by the doctor. And actually the makcik has a bit obese, yeah, but the obese person normally have a difficulty with their knee, yeah. So they, over time, they will have the osteoarthritis, yeah. The knee will crack, the knee will. So you can even imagine the makcik and all makcik and pakcik lah normally, right? Then they will walk very difficultly, yeah. They walk like ke samping macam ni, kan? You observe, yeah. Why they walk like that, it's because their knee is painful, okay. So then the doctor said, oh, makcik, you have to exercise. How to exercise? The knee is painful, right? Yeah, you cannot just tell the exercise. So this is like, you cannot exercise because your knee is having pain, and then you will gain more weight and more weight, yeah. And the more the weight you gain, the more the pain, the knee will pain, yeah. So what you call the vicious cycle, yeah, vicious cycle, right? So what we need to know, okay, for me, I like to suggest to the patients like this to have the static cycling, yeah, like static cycling, yeah. Maybe if you cannot have the bike, yeah, but you have to static cycling, but it's quite expensive lah, static cycling, yeah. If you cannot afford static cycling, probably you can lie down on the bed and macam mengayu sepeda bicycle, yeah, but on the bed, yeah. So teach the patient how to do lah, okay. So that is the safest one, I think. All right, and then these are all the lifestyle. Yeah, please read it because it's quite good information. Now, Joanne mentioned about statin. Yeah, so when do we start patient with statin? Okay, so when there is a very high or high risk. Okay, for this Alex is high risk, so we can safely consider statin. Yeah, congratulations, Joanne. You will become a good pharmacist later. You already start. Yeah. Okay, but you have to have a basic when you suggest. You cannot just out of mind. Yeah, because many people use statin, so we just suggest statin. Yeah, but there is in the guideline very high or high. Okay, even intermediate and low risk as well. Yeah, after there's a star here. After therapeutic lifestyle changes for those with intermediate and low risk, if their cholesterol is still high, yeah, their LDL, so then you suggest them statin as well. Of course, with a lower grade of statin, yeah, lower intensity. Okay, or you can combine here. There's a combination between statin and ezetimibe. When we combine these two, when there is a failure to achieve LDL. So the first choice is to combine with ezetimibe. Yeah, and there's a combination with this new drug PCSK9 inhibitors. Yeah, so when there is a more severe type, yeah, like familial hypercholesterolemia, etc. And can we combine statins with fibrate? Yeah, actually in general we avoid combining statin and fibrate. Yeah, except for diabetic patients on maximally tolerated statins. Yeah, when the patient have high TG, because why we use fibrate? Fibrate is for high TG. Yeah, so we only combine statin with fibrate because statin can lower down the TG but not so much. Yeah, so statin can lower down LDL, increase HDL, and lower down TG, but not so much. So we can combine with fibrate if we already use maximum tolerated statin, yeah, and plus the ezetimibe still high, then you can consider fibrate. But when we consider fibrate, you cannot use gemfibrocil. Gemfibrocil is the first fibrate, yeah, is the first fibrate, but you cannot use that one because the risk for myopathy is too high. Okay, if you need to combine the statin and fibrate, we will choose fenofibrate, yeah, or other fibrate, yeah, which is safer one. Yeah, okay, so this or we totally ignore statin if the patient becomes statin intolerance. Every time you start statin, then the liver enzyme increase 5 times, then you cannot give statin. Why? When you give medicine, so your principle is the risk and benefit. Yeah, you say that normally we say that the benefit and the risk. Yeah, so if you have risk, of course the patient have risk. For example, like patient have very high risk, but then if the liver enzyme increase very high, then the patient got risk of liver failure. Yeah, you save the patient from CVD, but the patient eventually die because of liver failure. Kan? Yeah, so then you have to maybe not to give statin, stop the statin, and then we give the ezetimibe only. Yeah, or we give the PCSK9, yeah, or fibrates, depends on which one. Yeah, so you can have a look more to read more the guideline. I won't be, yeah. So this is just the different drugs. Yeah, different drugs will work different. Yeah, so for example, like, so one drug also can have different mechanism. Yeah, if you see fibrates here, yeah, fibrates here, the main mechanism is to activate the lipoprotein lipase. Yeah, we just now we said lipoprotein lipase is good. So when you enhance lipoprotein lipase, you will break down more triglyceride. Yeah, so no wonder that fibrate is good for high TG. Yeah, because it activates the lipoprotein lipase. Okay, and ezetimibe here reduce the absorption of cholesterol. Yeah, and statin decrease the production of synthesis of cholesterol. Yeah, and statin also increase the uptake. Yeah, so these few drugs actually work together to increase the uptake. And our latest, yeah, in the family, that is, yeah, adik bongso kita, yeah, is the PCSK9 inhibitor. Yeah, so what is this PCSK9 inhibitor? Yeah, actually, so when statin, right? Statin, no, so when LDL, yeah, LDL, you need the LDL receptor, yeah, LDL receptor. So when LDL receptor receive the LDL, yeah, both the receptor and the LDL will go inside the cell, yeah. Then the receptor will be recycled, yeah, the receptor will be recycled, yeah, and PCKS9 enzyme, yeah, will increase the what you call the this destruction of the receptor. So inside the cell, so this PCSK9 will increase the damage of the destruction of the receptors, kan? So if you inhibit this enzyme, yeah, this is the antibody, yeah. So antibody inhibit this enzyme, yeah. So this enzyme, you see, the PCSK enzyme look like this, what do you call this, worms, yeah, look like worms. So this worm will destroy the receptor, yeah. Now you administer the antibody. This antibody will bind the worms, yeah, bind the PCSK9, yeah. Then your receptor will not have these worms, yeah. So when the receptor don't have this worm, so the receptor will be recycled, yeah, directly after apa down, what do you call this, getting out of this LDL, then the receptor will be recycled. This is the normal one, yeah. Receptor will be recycled. But if they are destroyed by the lysosome, they cannot be recycled, yeah. So in this way, yeah, this is the easiest way to understand how the PCSK9 works, yeah. Okay, back to our this one. So just now our first choice of combining the statin is to combine with ezetimibe. Yeah, why is the first choice to combine with ezetimibe? Because ezetimibe, yeah, will reduce the absorption of cholesterol from food, and statin is to reduce synthesis of cholesterol. So these two drugs, yeah, work to lower down the two sources of cholesterol, which is from food and from synthesis. Yeah. So now you can see they actually work hand in hand. Yeah. One is to prevent from the food one, another one is to prevent from the synthesis one. Yeah. Understand or not? Yeah. It really makes sense. Yeah. If we know the pharmacology. Yeah. So it's easier for us to understand the pharmacotherapy. Yeah. So everything in pharmacy is interrelated. Okay, are you happy to study pharmacy? Coba kita tanya yang cowok nih. Mana dia? Hilman, are you still there?
Yes, sir.
Are you happy to study pharmacy, such a feminine profession?
I think I'm quite happy, but it's quite hard.
Okay, Victor, you still there? Only two boys, yeah, in your class, yeah?
Four. There are four.
Five.
Only 5. Okay, who are they? Where? This one, Chua Sing Chua, yeah, Chua is your family name or your first name? Chua normally is family name, right? Your surname, yeah. Chua Seng, yeah, like that, yeah. Is it a girl or a boy?
Boy.
A boy.
His might not function.
Siapa?
His might not function.
Not functioning. Alasan dia tu. Siapa lagi? Kogulan is a boy or a girl?
A boy. Oh wait, no, man.
A man, yeah, not no more boy, yeah, man, yeah.
Yeah, sadly.
Okay, okay. All right. So we proceed. So this is a very good table from the CPG. So you can see how much of LDL, HDL can be changed by giving statin, for example. Yeah. So, and then you have this side effect, myopathy, increased liver enzyme. Yeah. Contraindication. So contraindication is, let's say if you have active and chronic liver disease, concomitant use of certain drugs because of the interaction. Yeah. For example, statin can interact with cyclosporine, for example. Yeah. Cyclosporine is used for example, after patient having the kidney transplantation, yeah, they will be given cyclosporine to prevent for rejection of the organ. Yeah. So if you give with statin, probably will increase the statin's level or increase the cyclosporine level. Yeah, they are both vice versa. So what should we do? Can we give or not give? Yeah, that we have to see. Yeah, to see risk and benefit. Okay, we can lower down the dose actually, kan? Yeah. So next. Okay, so if you read this like cyclosporine, macrolide antibiotic, antifungal agents, yeah, and fibrates and nicotinic acid, yeah, should be used with caution, yeah, with the statin. Okay. Now, so what is the problem with the ezetimibe? Here, this is ezetimibe, yeah, can cause headache, abdominal pain, and diarrhea, yeah, because they work to decrease the absorption of cholesterol, yeah. So then the cholesterol will be a lot in the gut, and they can cause abdominal pain and diarrhea, yeah. So it is like understandable. Okay, so now what is important for us also to know that the statins have different intensity. Yeah, high intensity statin depends on the type and the dose. Yeah, so basically atorvastatin and rosuvastatin, they are high intensity, but when they use in the higher dose. Yeah, and they can become moderate when they use a lower dose. Okay, and simvastatin, etc., 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 is the moderate if you use a moderate dose. But there is also low intensity, yeah, if you use a lowest dose of everything, yeah, so it becomes low intensity, yeah. So I think it's good to also to read this, yeah. High intensity statin is for patients who are at very high and high risk. Low intensity statin therapy is generally used for primary prevention after TLC and following a discussion with the patient of the risk and benefit ratio. Yeah, so I want to ask you your understanding. Yeah. So now this sentence first. Okay, for Mr. Alex. Mr. Alex have high risk or moderate risk? Or high risk or very high risk?
High.
High risk, yeah. So high risk, then we start with high intensity statin. So our next question, right, because that just now Joanne said, treat with statin. So the next question is, what kind of statin, which statin we should give? Yeah, whether we give simvastatin or we give rosuvastatin, which one? Okay, and which dose? So now the question is answered, yeah, that he needs high statin. Yeah, so high statin, you can treat rosuvastatin 20, yeah, or atorvastatin 40. Okay, so we straight away take the atorvastatin 40. We can straight away use 40 instead of starting first with 10 or 20. Yeah, so is there any like guideline, or I mean that if let's say the patient said, oh doctor, can I start with a lower dose first, I want to try. And some doctors also, some clinicians are more cautious, yeah. Instead of starting straight away 40, start first with atorvastatin 20. Do you think it is logic or not? like the atorvastatin can be from 10 to 80, right? 10 to 80. But if you say high intensity, you should be 40. But since the patient is the first time starter, yeah, the beginner, can we start with 20? What do you think?
I think can.
Can.
Huh?
Yes.
Yeah. So because there is no right and wrong with clinical pharmacy. Clinical pharmacy is not like mathematics. Yeah, there is no fast rule, hard and yeah. So if I would say if the patients are younger, yeah, then you can start away to start 40, no problem. Yeah. If the patient is a bit older, like elderly above 60, probably we more cautious. Yeah, we start with 20. Yeah, and then we monitor. If okay, then stay with 20. But if not enough, then we can increase to 40. Agree or not? Now, low intensity statin therapy is generally used for primary prevention. What is the meaning of primary prevention?
When you do not have any CVD attack yet.
Yeah, yes, correct. Yeah, so you don't have any CVD attack yet, then you be the primary prevention. Yeah, so because if you already have the attack, then it become the very high risk already. Yeah, then you have to use the high intensity. Correct. So now, what are the counseling points? Yeah, when can anybody tell me what are the counseling points? Just points. Yeah, points. The counseling points for statin.
Take at midnight. Take before
At
bed.
midnight. Who is this?
Anna.
Huh? Hannah. Okay. Midnight or at night?
At night.
At night, yeah.
Before bedtime.
Before bedtime. Okay. What else? Oh, that is for all the statins or only for some statins?
All.
Okay. Anybody else have a different opinion?
No.
No.
All statin.
Huh? Who is this?
So I said it's for all statins.
For all statins. Okay. So anybody else have different opinion? Iza, Kishantini, Arwa, mana Arwa? Arwa ini lelaki kah perempuan?
Perempuan.
Perempuan. Okay, Arwa. So all statin. Actually, not all statin, yeah. So, I mean, all statin you can take at night, no problem. But there are two statins, just now atorvastatin and rosuvastatin, you can take at any time. Why? Because they are what? They are long
High
acting.
intensity.
Nah, besides that, they are long acting, yeah. Because they are long acting. First of all, just now Hannah said at night. Why must be at night? Why is suggested to be taken at night? Why?
Production of lipid at night or what?
Yeah, correct. Yeah, because
Cholesterol.
cholesterol synthesis normally happens at night. But I'm not sure whether it is happen at night or it happens when we sleep. Yeah, because when we sleep, there are a lot of things happening. Okay, whether this is because of at night. If you don't sleep at night, will it produce or not? I don't know. Yeah, I don't know, but I think it is considered something with the sleep lah. Yeah, not the night, like the night. Yeah, but I'm not sure. I need to read more. Yeah, but we say that the cholesterol synthesis happens in the evening or at night. Yeah, so that's why we take in the evening, and then when it is a long acting, then you can take at any time, because it will affect also at night, because if you take in the morning, it is long acting. Yeah, make sense or not? So what are other counseling points beside the how to take? Yeah, almost time to end, yeah, the lecture. 10 more minutes. Okay. So anybody? Dah hypoglycemia semua ya?
How, how about side effect, Dr. Ben?
Yeah, side effect. How is that side effect? Ayo. Okay, so for counseling points at any drug, yeah, not only statin but any medicines, first we have to explain the aim of therapy. Yeah, tell the patients, makcik, pakcik, why you are prescribed this drug. Yeah, the aim of therapy. Okay, then from there, again, how to take this medicine is important. If there is a special way, yeah, like the just now we mentioned about short acting statins, take at night, etc. Onset, it takes 1 to 3 months to show the effect. Yeah, it's not like you take statin today, then tomorrow your cholesterol will be lowered. Yeah, so it's so then the patient also will have expectation. Yeah, not like, oh, after 1 month then you go to the pharmacy to take the cholesterol. Why still high? Yeah, then the patient by themselves take more statin like that, then end up with the rhabdomyolysis. Yeah. So you must say, okay, it takes time for this to work. And side effects, okay, important. Increase liver enzyme. Of course, you cannot tell the patient increase liver enzyme because the patient don't know what is liver enzyme, right? And you can also, can you see with your body, oh, my liver enzyme increased already, can or not? Cannot, yeah. So you will not be able to detect clinically. So what you do is, because if liver enzyme increase, it means there is a liver damage, yeah. So for example, if you notice any yellowish color in on your skin, yeah, or whether you have what, fatigue, yeah, feeling tired, yeah, because generic um, symptoms, yeah, of the liver failure. But of course we cannot overstress this one, because if you overstress this one, makcik pakcik, this drug can damage your liver, you know. Yeah, you better be careful if you have if you see any yellowish color on your skin. If you say this, what will happen?
They won't take it.
Yeah, they're scared. Yeah, why I want to take this, and then my liver got problem later, kan? And then it increased risk of diabetes, but this is very mild, normally at the initiation. Yeah, so it means that you don't overemphasize on this. Yeah, but just to be cautious, because patients when before this I don't have my blood sugar is normal. Why after I take statin, my blood sugar start to increase? Yeah, so there is actually some relation. Okay, myopathy, muscle pain. Yeah, so and this is quite difficult also because already elderly or they have muscle pain, isn't it? Yeah, but this muscle pain is without any reason. Yeah, not like after you got sprain, yeah, or after walking too much, then you have muscle pain. Yeah, but this is without reason. Okay, and it's also correspond with the start and of the drug. Like after you starting the drug for maybe a few days, then you have muscle pain. Yeah, or 1 week, then you have muscle pain. Not like after you take the drug for like 2 months only you have muscle pain. I think that is not so logic. Yeah. And rhabdomyolysis. So this is related between muscle pain and rhabdomyolysis. You heard about rhabdomyolysis, yeah? What is rhabdomyolysis actually? Rhabdomyolysis is the breakdown of muscle, yeah? Breakdown of muscle. So it causes pain, but muscle pain is a bit more mild, not severe. But rhabdomyolysis is severe because when the muscle break, yeah, it will produce myoglobin, and myoglobin is the poison, yeah, it's poison for our kidney. So it will end up with a kidney problem later on if we don't treat. Yeah, so there will be dark colored urine and extremely rare, because this rhabdomyolysis is extremely rare, so we cannot overemphasize to the patient. Yeah, but just tell the patients very rarely happen, but if you happen to notice this, yeah, please tell the doctor. Okay, drug interactions, this medicine interact. So actually statin have many drug interaction because it is substrate of cytochrome A34, yeah, 3A4. 3A4. Yeah. So it is a lot of interactions. You cannot say one by one to the patient. Yeah. But you can tell that this medicine interact with many other drugs. Consult your doctors or pharmacists before taking other medicines. Yeah. And the most important, like grapefruit juice, because grapefruit juice, patient can grab grapefruit. Yeah. Actually, what is grapefruit? Yeah. Do you know what is grapefruit?
Limau gedang.
Limau gedang, ya, yang besar tuh ya. So it is not, before that ya, people think grapefruit is anggur atau buah anggur. Ya, it's not buah anggur ya. It's limau yang I think sometimes you can see it in giant, right? Okay. So how to monitor the therapy? What are the things to monitor? Okay, so first you must monitor the achievement, yeah, whether the target achieved or not, yeah. But you check only in 3 months, then in every 6 months. Yeah, don't be too aggressive as well, yeah. And liver enzyme ALT AST check within 1 or 3 months, then every 6 months. If tolerated, it is not necessary to check regularly. If the patient tolerate the statin, then no need to check every time, yeah, because it's costly, you know. And then symptoms of pain, muscle pain, rhabdomyolysis, dark color urine, and CK. That if the patient have, for example, patient have muscle pain, and there is you suspect rhabdomyolysis, then we can ask the patient to to check the CK, because our muscle have a lot of CPK, yeah, creatinine kinase, yeah, creatinine phosphokinase. So when you have muscle breakdown, the CK will increase. And drug interaction as well, yeah, and compliance, adherence, yeah. So you must ask the patients about the adherence. And then, so our case continuation, the patients was prescribed atorvastatin 20. Yeah, just now we decide whether 20 or 40, but actually the patient is a bit younger, so we can start 40. Yeah. After 3 months, he has another appointment and he tried to quit smoking, but not very successful. And his medicine now is lisinopril, atorvastatin, and metformin. Yeah, he claims that he adheres to low carbohydrate, low saturated fat, etc. His body weight gone down to 65, but gone up again. He claims to have brisk walk around his housing, around 30 to 60 minutes on weekends. Is it enough? On weekends only, yeah, 30 to 60 minutes. Enough or not? Yeah, it's not enough because guidelines say at least 3 times a week. At least 3 times a week, yeah. But we must encourage lah to say that, oh, good, yeah, please continue. But if you can, yeah, please do more. Okay. So now we have the total cholesterol, which is still high. Yeah. And the most important is we remember that we need to get the LDL below 2.6. Yeah. But the LDL is still high. And the AST, ALT is a bit higher than the highest level. Yeah, a bit high. Yeah. So there will be a question, has the lipid MAR therapy achieved its target? Not yet, yeah, because it's still above the 2.6, yeah. And then in view of that, his ALT and AST have increased, slightly raised. Can we safely continue statin? Nah, yeah. So from the Malaysian guidelines, CPD, yeah, stop statin only when ALT, AST raised 3 times higher than their upper limit. So that's your upper limit 40. So if the ALT AST raised above 120, only you stop statin. Yeah. But other literature said 5 times. Okay. Malaysian one is most strict. Yeah, 3 times. Others said that okay, if 3 times you ask the patients to be careful. Yeah. But if 5 times, definitely you must stop. Okay. So weigh the risk and benefit. We have to weigh the risk and benefit. Yeah. The manfaat dan the mudarat, ya. Ya, Bu Enti, ya. And then what option is available to optimize the dyslipidemia therapy? So we have already seen there is a combination therapy. So for this patient, so which one you will suggest for this patient? Will you increase the statin first, or you start plus ezetimibe? Which one? Which one do you think? There's another option is to increase the statin, right? Because the statin only 20. Then you can increase to 40, yeah? The atorvastatin. Yeah, and see. And then the second option is you combine the statin with ezetimibe. Because the best is statin with ezetimibe, yeah? It's the first line combination, yeah? So, so which one do you think better? I think this is the last slide or the second last slide, yeah? So which one do you think better? Hello? Hello, doctors. If doctor ask you lah, yeah? What do you think? Pharmacist biasanya malu-malu terus, ya? Apa? Siapa?
I think we have to give statin to the maximum dose first. If still not working, then we can combine.
Okay, so Fida said, give first statin increase to 40, yeah? Agree? Yeah?
Yes.
And monitor, okay? I mean, you can do that, no problem, yeah? There's another, do you have any other option? Semua setuju dengan Fida? Hena? Ima? Setuju je lah.
Maybe can combine with ezetimibe
Yeah, why you prefer combine? Why?
for better effect.
Karena apa? Better effect, and then what else?
Can reduce the side effect.
Reduce the side effect, Putri said. Yeah, which side effect?
Like if you use high dose of statin, it might give greater side effects. So if we combine, we can reduce the statin level, so the side effect also will be lower.
Okay, so which side effect you're talking about for Alex?
Increase level enzyme.
Increase enzyme, yeah. So see, yeah, here actually, if you want to take the Fida's advice to increase 40, it's still okay, yeah, because the enzyme is not too high, right? Still okay, but then you have to check within 3 months time, yeah, whether the enzyme is, and then you have to warn the patient. The other thing that Putri and Ima said, that to give ezetimibe, yeah, because we are cautious. If the clinician is cautious, oh, the liver enzyme is already increased a little bit, so we don't want to, you know, to make the patient in danger with giving more, yeah. So why not we just combine with statin, combine with ezetimibe, because ezetimibe have less side effect, yeah. So I think for me, I would go the second one, yeah, to plus ezetimibe, okay, because of the liver enzyme increase. Yeah, I'm a bit worried also lah. Yeah, but all depends on the patient actually, kan? Because actually sometimes atorvastatin 40 milligram and 20 milligram, they are the same price, you know. So for if the patient have to pay, probably that is the safest one. Yeah, cost saving, more cost saving. Yeah. And I don't know whether KK or Malaysian hospital will provide ezetimibe or not. I don't know, because ezetimibe is still quite new. Yeah, I'm not too sure. We have to check in KK. Yeah. I think then next is thank you for your attention. Any question or not? Any question? Do you feel boring with my lecture? Huh? Any question? Tak ada? So let's turn on your video, and then we have a screenshot, yeah, to show Prof. Eddie that I have already given the lecture.
Evidence.
Evidence.
Okay, evidence.
Evidence-based lecture. So do you enjoy the lecture, Joanne?
Joanne.
Yes, sir.
Tong Joanne. You know, I have a very good friend, Prof. Tong from UKM. Yeah, he's from professor of family medicine. Yeah, Prof. Tong. Okay, Amuta. Sivalingam.
Sir.
Hi. There's because before I used to work in IMU, there's a professor of gynecology, yeah, Prof. Siva. Okay, who else? Ayo, jom. Kogulan, where are you? Why are you wearing mask? You're not at home?
He always wear mask.
Oh yeah? Even at home also?
Yeah. Apparently. No, I'm just kidding.
I'm very lazy wearing mask. Okay, siapa lagi? Siapa? Yeah, the JGUs, like students also, please show yourself. Don't be shy. Oh,
Sir,
Rishi.
sorry, so I cannot turn on my camera.
Oh, okay. No
Sorry,
problem. Yeah, no problem. Okay. I just take the first shot. Yeah, 1, 2. Wait. I just now earlier I took a shot. I will give to this one first. Oh no. Wait for a while. I take the shot. Screenshot. Okay, and then I'll share with Miss Anty first. Second one, because they have got a lot. Yeah, second one. Okay, 1, 2, 3. So sorry to take your time so much. You have got another class now. I understand. Or now or later at 2 o'clock?
At 2.
So you can have. Wait, I just want to take the screen of this Wait. Wait. I'm giving another class, another lecture about with the same 7. Yeah, if you want to come, also can. If you want to listen.
What time?
On the 23rd, not now. On the 23rd, about
23rd.
Pharmacist collaboration with doctors and other health profession.
But you have another lecture later on by next week on Monday.
My lecture?
Yes, interprofessional.
Yeah, that one is with with you or with the SEM 7?
With me, yeah, with SEM 7. This student also need to join.
Oh, sorry. This is Miss Anty. I thought you are student talking. Sorry. Wait, I want to do this screenshot first. Just wait for one. This epidemia, okay. Okay, this lipidemia. Wow. Okay, here. All right. One, two, three. Okay. Okay, I'm done. Okay, have a good afternoon, everybody.
Thank you, Pak Benny. So
Okay.
I hope you all understand how to categorize the patient, and after that, what is how the approach to manage, okay? And then what is the drug selections for these patients, okay, something like that. Okay, that is a clinical. Okay, so we will see Pak Benny on Monday.
Okay.
With another lecture.
Now let's go to Mama.
Yes, let's go. All right, thank you very much, Pak Benny.
Nasi lemak or roti canai. Okay,
Roti
bye.
canai.
Bye. See you
Thank
all.
you.
Thank you.
Thank you, sir.
Bye.
Bye for my
Bye,
students
sir.
also from
Bye,
JGU.
sir.
Bye. Thank you. Alfi, Umi, Rindi, Rini.